Hi, this is Andrea Kane, and I'm here with you for HIT 120 Pharmacology. We are now on week 16, and I am sad to say that this will be the last lecture video I do for you. But I hope it's a good one. We are going to talk about case studies. We're really kind of trying to pull together everything that we've learned this whole semester in pharmacology, and we're tying it into pathophysiology and coding because really, hopefully, as you have found throughout this semester, pathophysiology and pharmacology sort of get braided together for coding. And so we need to take a look at that. How is that done? What does that mean? What would you need to know to be able to apply it? Because after all, this class is pharmacology for HIT, so let's talk about it. All right, I want to talk to you about reviewing cases when it comes to ICD-10 coding. And this is just based on my own personal experience as a coder, because I have done coding throughout my career multiple times. And this is just gleaned from my experience. So you can take it with a grain of salt. Probably other coders might potentially tweak this a bit, but hopefully it's representative of what most coders would do. All right, so ICD-10 basis. You want to read through the scenario a few times. Jot down notes about what is wrong if you can. A lot of times you can keep a piece of paper by your desk, and if you're using electronic records, you can just scribble some notes. But sometimes it's helpful to do this, especially as a new coder, because it can be very overwhelming if all you're doing is looking at it on the screen. So sometimes it helps me when I'm coding, especially a very complex case, to be able to jot down notes. What is wrong with a patient based on the documentation? H&P, consults, op reports, progress notes, path reports, wound care notes, rehab assessments, vent records, body mass index documented from nursing, those types of things. What's wrong based on the documentation? Then what is wrong based on the test results? For instance, labs, radiology, if they did a swallowing test, if they did nuclear medicine test, an EKG, those types of things. What is wrong with a patient based on medications? If the patient's being treated with a whole long list of medications or a couple of medications, doesn't really matter, what do those medications imply about the patient's condition? What is wrong with a patient based on the treatment or services that are provided? So for instance, if you see that a patient is receiving respiratory therapy care and nebulizer treatments, what is that implying about what's wrong with the patient? Or if the patient's receiving physical therapy, again, what might be happening there? What is wrong with a patient based on the final diagnoses? So when you're looking at that discharge summary, you want to know what are in the final diagnoses. So what you're going to be doing as a coder is putting all this together. The next question I like to ask myself is there any missing information that I can find elsewhere on the chart that'll impact the patient's final diagnosis? So if I've looked all those other places, I have what I need, then I don't need to go any further. But if I'm missing something and I might need to go look something for somewhere else, then I need to ask myself that question and go look. I also need to ask myself, is there any missing information that I cannot find elsewhere in the chart that will impact the patient's final diagnoses? So let's say we're dealing with a sepsis case and we're trying to figure out, is this regular sepsis, severe sepsis, or septic shock? And I'm not able to find the information that we need to clarify that for the patient's final diagnosis. That's important to know. Because if I do need that missing information and I can't find it anywhere else, it may mean that I'm going to need to query the physician, which is the next question. Do you need to query the physician? If so, why, and specifically about what? You don't just go ahead and whip off a coding query to a physician or a coding clarification. You need to make sure that you understand, why do you think you need a coding query or coding clarification? What is it specifically about? And then you need to ask yourself, before I even do a query or a clarification, do I have the clinical data and chart documentation to build that query or clarification without it being leading? So these are all the things that when I'm reviewing a case as a coder that I am asking myself, thinking about, exploring, and whatnot. When it comes to CPT-4 coding, again, you want to read through the scenario a few times. You want to be able to jot down notes if you can. The biggest thing that I jot down notes for when I'm coding CPT first of all have to do with E&M coding. If I'm doing E&M level coding, then I need to jot down notes about medical decision making or time or things like that, so that I'm sure that I understand what's going on from that standpoint. Is it an established patient? Is it a new patient? Which setting are we in? Are we in a hospital setting? Are we in a skilled nursing facility setting? Are we in the home? Are we in the hospital? Is this a consult? Is it an H&P? Is it a discharge summary? Is it simply a daily visit for like a progress note? What all is going on that I'll need to know when I build that E&M code. Next thing I like to jot down notes about is what I need to know about the provider's performance of services. For instance, was an EKG performed that the provider interpreted? Or which surgical procedures did this particular provider perform that we're going to need to code in CPT for billing purposes? Whether they were, for that piece, for that physician billing piece. Or in the hospital setting, on the outpatient side, if you're coding CPT for an outpatient hospital outpatient setting or that type of thing. I ask myself, is there any missing information that I could find elsewhere in the chart that will impact provider coding, whether that's E&M or the service procedure? Is there any missing information that I cannot find elsewhere in the chart that's going to impact physician coding, physician or provider coding? And what do I need to, and do I need to query the physician? If so, why, and specifically about what? And do I, again, have the clinical data and the chart documentation to be able to build the query or clarification without it being leading? Those are all the things that need to go into that consideration. So enough about all of that background. Let's actually dive into a scenario. So scenario number 1. We have a discharge summary. It is by the attending physician who is an internal medicine physician. It is a 78-year-old female with a long history of Crohn's disease and multiple procedures for segmental small bowel resections. She has had 2 chronic non-healing fistulas and has been chronically malnourished while living alone. Over the past several months, the physician says, when I have seen her, she has had progressive weight loss, fatigue, breathlessness on exertion, and general decline in her overall status. She was admitted for evaluation and possible hyperalimentation. She has an unremarkable chest x-ray. Her EKG showed frequent but low PVT, premature ventricular tachycardia, in case you're not familiar with that, left axis deviation, and QT prolongation. Her hemoglobin is 11.4, sodium is 129, albumin and total protein markedly reduced at 1.6 and 3.7 respectively. Cholesterol was 32. Surgery was consulted. Then they placed an indwelling superior vena cava catheter for hyperalimentation, which was then begun. Hospital course was complicated by fluid retention and dependent edema. Discharge was to a local SNF for rehab and continued hyperalimentation on an outpatient basis. Discharge meds include Lasix and prednisone. No activity restrictions. Follow-up appointment made with a cardiologist, and patient is stable, somewhat improved at discharge. Final diagnoses include Crohn's disease with chronic malnutrition, non-healing abdominal fistulae, and electrolyte imbalance. All right, that's our scenario. My questions for you are, what do you already know about Crohn's disease? What do you already know about multiple bowel resections and abdominal fistula? And let me slow down for a minute. What do you know about Crohn's disease? Well, you need to know that Crohn's disease is an autoimmune type of situation. So what kind of meds would you expect someone on Crohn's disease to be on if you're dealing with an autoimmune situation? And does that and is the patient already on that? We're gonna kind of notice that. What do you already know about multiple bowel resections and abdominal fistulae? Well, you know that with multiple bowel resections, she's obviously got a pretty sensitive abdominal area and high potential for abdominal adhesions and probably some issues with healing because they have these non-healing abdominal fistulae that don't seem to be able to be addressed. So we know from the Crohn's disease, the multiple bowel resections, and abdominal fistulae, this person's going to have digestion issues. And so we're not exactly surprised when there's malnutrition. So keep that malnutrition in mind. Next question, is the EKG's interpretation of importance? Well, is it? If so, why? And if not, why not? Ask yourself those questions. Make sure you can answer those. What does PVT with QT prolongation suggest? If you're not familiar with that, and I didn't remember what it was, so I had to look it up. The condition is called torsade de pointe, or torsade de pointe. That is a French term, and I'd encourage you to take a few minutes and Google that. Is it serious or life-threatening? You might want to be aware of that. Is that something that wasn't addressed in that discharge summary that might need to be coded, might need to be queried? Hint, hint, hint. What else about the patient's test results are abnormal enough to be of concern? There may be, there may not be. But you need to ask yourself, is it abnormal enough to be of concern? Did it play into anything else? And this is where I want to kind of key you back in to thinking about the Crohn's disease and multiple bowel resections and abdominal fistulae. The other thing that was really abnormal about this patient's test results beyond the EKG's interpretation were albumin and protein. I mean, cholesterol was really low, but the albumin and the protein are so reduced that plays into malnutrition. And if you're familiar with coding malnutrition, there are different types of malnutrition, and you have to be very, very specific and have lots of backup documentation in order to code chronic malnutrition. It is an MCC, a major complication comorbidity, and so it affects the DRG payment. It's also on multiple lists of codes that are codes and DRGs that are investigated for fraud or abuse. So you have to be very careful, excuse me, about all of that and make sure you have the background information that you need. So because it looks like in this case we have two opportunities for query. We have the EKG and the PVT with QT prolongation. We also have the severely abnormal protein, and which may be associated with that chronic malnutrition. All right, what do fluid retention and dependent edema imply? So let's really quick go back here and look at this. It doesn't mention anything in the final diagnoses that would include that fluid retention and dependent edema. All right, and this is where your anatomy, physiology, pathophysiology knowledge is really going to come into play. If you have a patient who develops fluid retention and dependent edema, and they have a seeming cardiovascular problem, and they're discharged on Lasix, what does that tell you? It tells you opportunity for query, because perhaps this patient has some congestive heart failure. So, and that, again, depending on the specificity of that may also influence the coding of this case. All right, so what do the discharge medications tell you about the patient's condition? That's where you've got the Lasix and the prednisone. The Lasix obviously is to handle the fluid retention and dependent edema, and the prednisone is obviously for the Crohn's disease. And then he mentions in this that the physician mentions in this that the patient's going to have hyperalimentation on an outpatient basis. So that would indicate treatment of the chronic malnutrition. Is there any additional information you wish you had about this patient for ICD-10 or CPT coding? Well, let's stop for a minute and talk about CPT coding. We were clued in here that this is an established patient because it says over the past several months when I have seen her. So obviously this physician, this internal medicine physician, has seen this patient prior to the hospitalization. So this is an established patient for this physician. So that would be something you would want to know for CPT-4 coding, right? For the E&M level, if that's what you're doing. As a coder, would you need to query the physician to obtain any of this additional information? If so, what and why? If not, why not? So ask yourself those questions. Based on what is coded here, do you have enough that you don't need any additional information, that you can just code it as is and nothing else really matters? Or is there something significant enough about this case with either the EKG or with the albumin, total protein, and chronic malnutrition, or the hospital course complicated by fluid retention and dependent edema with a discharge med of Lasix, that would help you be able to build that coding clarification or coding query appropriately to gather that information. So just thoughts to think about. Let's move on to scenario number 2. Scenario number 2, we have a discharge summary. This time it's by a hospitalist who has only seen the patient for the last 2 days of her admission. We need that context for CPT coding for E&M levels, but also to understand what we're dealing with this discharge summary. Okay? 84-year-old female with long-standing severe congestive heart failure who was just discharged from this facility 2 weeks ago for an acute exacerbation of chronic congestive heart failure. On the day of admission, according to the H&P, patient presented with acute bronchitis complicated by another acute exacerbation of congestive heart failure. Labs were normal except for hemoglobin that was slightly low at 11.4 and sodium at 127. EKG showed atrial fibrillation with controlled ventricular response and evidence of an old aneroseptal myocardial infarction. Chest x-ray showed some interstitial edema and subpulmonic fluid consistent with congestive heart failure. Patient was treated with parenteral bronchodilators, broad-spectrum antibiotics, and inhaled bronchodilators. Patient was continued on her routine CHF and AFib medications. Initially, patient showed significant improvement. However, on day 3 of hospitalization, patient unexpectedly became hypotensive and bradycardic, resulting in transfer to the ICU. Shortly after arrival in the ICU, patient coded. As patient had active DNR, resuscitation was not performed. Patient pronounced dead at 2:38 p.m., family and funeral home notified. Final diagnoses, recurrent bronchitis superimposed on acute congestive heart failure. Cause of death was ventricular fibrillation followed by asystole. All right, some questions for scenario 2. What do you already know about congestive heart failure? One of the things hopefully you know about congestive heart failure is it can be acute, or it can be chronic, or it can be acute on chronic. It can be left-sided or right-sided. And one of the things, did you notice about this? He never tells us whether it's left or right-sided. So we would need to look elsewhere in the record to find that clarification. And that leads us to the next one. What additional information do you need to know about congestive heart failure to code it to the appropriate level of specificity? And where in the chart would you go to find this information? I would check first with the H&P and then see if there were any cardiology consults or anything like that done. What do you already know about atrial fibrillation? And what do you already know about acute or recurrent bronchitis? Because all of those play into this. Is there any additional information you wish you had about the patient for your ICD-10-CM or CPT coding? And as a coder, would you need to query the physician to obtain any of this additional information? If so, what and why? If not, why not? So is there anything with this patient that you might need to query about? Well, the first thing is that if we can find more information about that heart failure, that congestive heart failure in the record, in the H&P and a consult, that type of thing that clarifies whether it's left or right, then that would be very helpful, because that again helps us get to that specificity. And same thing might be true of AFib, but I would say probably not. It's not going to adjust anything significantly enough in the end. So I'm not sure that you would do that. Again, with the bronchitis, there's not a whole lot that you've got to be able to go on. So this may very well be a case where you can find what you need in the documentation in the chart, and there is no need to do a coding clarification or query. All right, last scenario, because we're going to do three scenarios here. And then just so that you're aware, your quiz this week is actually 5 cases, but they are very short and they're short answer. So it shouldn't be too terrible. Last one, discharge summary. This discharge summary was done by an ear, nose, throat ENT surgeon who is the attending. Final diagnoses: left posterior epistaxis, platelet function defect secondary to aspirin use, adenocarcinoma of the lung, and essential hypertension. 59-year-old male admitted to the hospital through the ED following 3 episodes of bleeding from the left side of the nose. He was on antihypertensive medications, had a thoracotomy approximately 10 days ago for that lung cancer. Because of a suspicion of a left posterior epistaxis and this patient's aspirin use, he was admitted to the hospital for possible transfusion and exploratory surgery. He was seen in consultation by his internist on admission to the hospital. The patient remained relatively stable. However, he had 2 episodes of bleeding while in the hospital. The platelet aggregate studies were abnormal, indicating interference due to aspirin-like compounds. When the patient had his second episode of bleeding in the hospital, it was elected to explore the nasal cavity and nasopharynx under general anesthesia. There appeared to be a bleeding site at the posterior end of the left inferior turbinate. Using a transnasal as well as a transoral nasopharyngeal approach using laryngeal mirrors, the bleeding site was controlled with cautery. Several other areas in the nose were cauterized as well. These may have been related to trauma from the suction tip and instrumentation of the nose that was in the nose. Patient's post-op course was satisfactory. Post-operatively, his blood pressure remained a little bit high. Packs were removed from the left side of the nose on the first post-op day. The patient was discharged to be seen for follow-up visits. It was elected not to restart his aspirin, Persantine, or Maxide at the present time. Okay, what do we already know about epistaxis? Which is basically a fancy term, medical term for nosebleed. What additional information do you need to know about the surgery to code it to the appropriate level of specificity in ICD-10, PCS, and CPT-4? Be thinking about that. Where in the chart would you go to find this information? Ideally in the operative report. What additional information do you need about the additional nasal sites that were cauterized due to trauma or instrumentation? And this is really an important one for us to talk through because they didn't plan to do those additional nasal sites. And it sounds like from the documentation that the additional sites occurred, began bleeding during the procedure and needed to be dealt with at that point. And so this brings up the question, when would you code something as a surgical complication versus when would you simply code what happened as it is a well-known, unavoidable, or inevitable effect of performing the procedure? And I'm going to cover that in the next slide. So let's leave that here and go on. What do you already know about poisonings and adverse effects regarding aspirin? What additional information do you wish you had about this patient for ICD-10-CM or CPT coding? And as a coder, would you need to query the physician to obtain any of this additional information? If so, what and why? If not, why not? All right, so with this patient, it's pretty straightforward. We have what we need about the epistaxis. There's no mention in here of hemoglobin, but that is one thing I would probably, this patient's had quite a bit of bleeding. So they may have a low hemoglobin, which may indicate hemorrhagic anemia. So that might be something that you would want to go and look at the lab results and see what this patient's hemoglobin is. Is it abnormal? If it is, you can query the physician because you have that low hemoglobin. You have the fact that this patient has had some bleeding, and you can be asking the patient or asking the physician if that is inappropriate, asking them in a non-leading way, what does it indicate when the patient had low hemoglobin and they've had bleeding? Is there a diagnosis code that reflects that? And then in terms of the procedure itself, you would code that off the operative report. And we'll again talk about those sites and whether or not you do anything with that from a query clarification standpoint or a coding standpoint. It sounds like the areas that were additionally cauterized were very close to the area that the procedure were performed, essentially in that same area, not the site, but in that area. So it wouldn't necessarily need to be any additional coding in terms of the procedure. And then, like I said, I'll talk to you about the complication piece. And then in terms of the aspirin use, obviously the patient was using the aspirin. It doesn't say he was misusing them, but that he was using them. So you'll have to determine when you go to code that as that was it an adverse effect, accidental, what was the situation? Based on what we know here, it sounds like it would be an adverse effect that was playing into this for that platelet function defect, basically meaning that patient had clotting issues. All right, so let's go on. Let's talk about what is a complication. And I'm going to tell you that when I was the director of an HIM department, and this has happened to me more than once in life, I had coding policies and procedures that we also trained our physicians on, our surgeons on. And this slide is directly from that. It's taken from the materials that I used to train physicians in documenting surgical complications, as well as trained coders in to code. And it's from Coding Clinic and CMS definitions and lots of years of experience. So here it goes. I hope that wherever you end up coding, if you end up coding, that they have something like this in place so that they're able to give you very clear direction and consistent direction for how they handle these things. So what is a complication? A complication is a condition that when present leads to substantially increased hospital resource use, such as intensive monitoring, expensive and technically complex services, and extensive care requiring a greater number of caregivers. That is the CMS definition of a complication. In terms of Coding Clinic, it's more than a routinely expected condition or occurrence, and there is a cause and effect relationship between the care provided and the condition, and there is provider documentation that the condition is a complication. You have to have all three parts, according to Coding Clinic, in order to code a complication. And it's very wise if you also make sure that it meets the CMS definition before you call it a complication. So what should be documented? If you have, so here's what we said to physicians. You need to document the occurrence. You need to tell us whether it was accidental or inherent to the procedure and how you handled it. How did you fix it? Was the puncture, laceration, tear, fracture, burn, hematoma accidental? Was it not expected, unlikely, or unusual to happen based on the surgical procedure being performed? For example, a bladder nick during an OBGYN surgery. That is not likely or usual to happen. Lacerated bile duct during a cholecystectomy. That is definitely not something that should be usual or likely to happen. Fracture during an orthopedic surgery. They do happen, but they're not likely and they're not usual. Puncture of an intestine when inserting ports for laparoscopic approach, resulting in conversion of the procedure to open. That is not likely or usual. A pneumothorax that occurs when an interventional radiologist is doing a thoracentesis or a pulmonologist is doing a thoracentesis. That is not likely or usual. In all of these examples, what do you notice? Wasn't likely, wasn't usual, and leads to substantially increased hospital resource use. Those are complications. Was the puncture, laceration, tear, fracture, burn, hematoma inherent? It was not a if it's inherent, it is not a complication, meaning that it was expected or likely to happen because of the surgical procedure being performed or because of the patient's anatomy or something like that. So what are some examples of something that is not a complication? If you're doing an enterotomy during extensive lysis of bowel adhesions, that is not a complication. When you're trying to peel back bowel adhesions, avoiding tears or a laceration or puncture of that bowel is almost impossible. And to fix it is very, very easy. It might be a couple of sutures. It's not intensive monitoring. It's not expensive or technically complex services. It's not extensive care requiring a greater number of caregivers. It doesn't lead to more days in recovery. So therefore, it is not a complication. Conversion of a procedure from laparoscopic to open due to the presence of thick intra-abdominal adhesions. This is one of those things where you open somebody up and maybe they've got all these intra-abdominal adhesions and you're going to have to convert the procedure from laparoscopic to open. Again, any other surgeon that's in that situation is going to have to do the same thing. It's based on the patient's anatomy. It's based on the fact that you can't perform a laparoscopic procedure if you're dealing with all these thick intra-abdominal adhesions. So in those cases, not a complication. So going back to our scenario, let's really quick jump back to our scenario. It says here that they may have been related to trauma from the suction tip or instrumentation of the nose. They were just cauterized. They were just cauterized. So let's go back to our definition. Were they inherent, likely to happen because of the surgical procedure performed? Well, yes. A nose is not a very big part of the body, and you get instrumentation up there, you get suction up there, you get a scope up there, you get all these things going on, and you've got a patient who already has a tendency to bleed because of the aspirin issue. This is not a complication. It's inherent. It's like expected or likely to happen based on the situation. So that is why you would not code this repair as a complication. This areas of the nose that were cauterized as well, related to trauma. You would not code those as complications because they're inherent based on the patient's situation, based on the procedure being performed, and the fact that they didn't require all these resources, all these extensive resources for the situation. So I wanted to cover that with you. I hope that will help you later in your coding career if that's the way you go. I found this to be very helpful. It was developed with legal, it was developed with risk management, patient safety, surgery, and physicians at the organization that I worked with. We did this together, and it came out over time. It came out through some things that we found in the peer review process. It came out in things that we found when we were coding, and as we worked with physicians in doing orientation. And so for us, this was a really beneficial and valued, and a lot of our surgeons found this information comforting and helpful to them, so that they knew what to do. Just because a complication occurred doesn't necessarily mean lawsuit, doesn't necessarily mean bad thing. Complications happen. And that's why when you're doing the consent form, you talk about risks, benefits, alternatives. And risks include things that are going to happen and complications. So in those cases, it's not necessarily a bad thing, but it's helping document it factually and clearly so that for coding and billing and even legal reasons, it's appropriate and clear. All right, so quick quiz questions that I wanted to ask you to think about. When coding, why is it important or helpful to use your pathophysiology knowledge? Why is it so important when you're coding to do that? To understand what a disease is and how it works and what it's treated with and how it can impact things going on in a person's health. When coding, why is it important or helpful to use your pharmacology knowledge? We've learned a lot this semester in pharmacology. How is that helpful? And why is it important to be able to use that? What does that tell you? How do pathophysiology and pharmacology play a role in building a coding query or coding clarification that is not leading? So be thinking about those things. And hopefully you will find that when you get to the quiz, having gone through this lecture, it will not be too bad. I tried to pick easy scenarios for you. All right, have a great week. If you have any questions, shoot me an email. And thank you so much for being a part of this class. Thank you for letting me be a part of your learning experience at NICC. And I look forward, hopefully, to having you in my classes in the fall. Take care.